AETCM. Today's case will be about a 56-year-old male hailing from Kollam, an ex-serviceman, who came with complaints of sneezing and rhinorrhea with postnasal drip for the past 5 days. He also had complaints of cough, which was insidious in onset, intermittent with no aggravating factors for the past 3 days, associated with yellowish-white mucoid sputum, which is scanty, non-foul smelling, with no positional or diurnal variation. For the past 2 days, patient had complaints of chest tightness and shortness of breath, grade 2 to grade 3 MMRC, and noisy breathing. Patient did not have any complaints of fever, chest pain, hemoptysis, or sore throat. There was no complaints of loss of weight, loss of appetite, loss of taste, or night sweats. And there was no complaints of rash, fatigue, orthopnea, or paroxysmal nocturnal dyspnea. Past history. There was no history of TB, COVID, pneumonia, asthma, obstructive airway diseases, allergies, or inhaler use in the patient. Treatment history, patient, it was nil significant. Personal history, patient had adequate sleep and appetite, regular bowel and
not on any medication.
No, sir. Personal history, a patient had adequate sleep and appetite, regular bowel and bladder habits, and he was an occasional alcoholic. Patient had no.
What is this occasional alcoholic? Can you explain?
Sir, just for celebrity.
See, the problem is when you write alcoholic, that insurance company will catch on that word. Alcoholic means what? Occasionally patient takes alcohol. That is different from occasional alcoholic. What is alcoholic? What do you mean by alcohol?
Daily intake of alcohol.
How many persons are taking alcohol daily? They are not alcoholic. 30 ml per day is acceptable. It is good for health. I'm not advising you to take that. It is acceptable. But what is alcoholic? So when we are writing all these things in case sheet, we have to be very careful. Alcoholic means meaning is entirely different. So that destroys his social life. That is alcoholic. Patient requires to take alcohol every day, and even that destroys his social life. Then only you can call him as alcoholic. He takes occasionally 1 pet or 2 pet. They are not alcoholic. Okay.
Patient gave history of occasional use of alcohol. No recent history of travel, and family history was insignificant. So to summarize my history, a 56-year-old male, an occasional alcoholic, an occasional patient who occasionally consumes alcohol, with no known comorbids, presented to the emergency department with complaints of rhinorrhea and sneezing for the past 5 days, cough with yellowish white scanty mucoid sputum for 4 days, and chest discomfort with grade 2 to grade 3 shortness of breath for the past 2 days. So based on my history, the possible differentials would mostly be suggestive of a viral bronchitis because of the duration, the symptoms, and the presence of noisy breathing, along with the prodromal symptoms, mostly suggestive of viral bronchitis. The possible other differentials could be a common cold, or an influenza, or an asthma exacerbation.
But he's not an asthmatic.
Yes,
No?
So less likely.
He never had asthma.
No, sir. So it's less likely to be an asthma exacerbation given the age of the patient, which is 57, and no
What
history.
is late onset asthma? Is there an entity like that? So asthma can start in age. Later part of your age also it can start. But here, since there is no past history, it is not at all the first set of differential diagnosis. It can be last.
Yes. So based on the above mentioned complaints, I'd like to further evaluate the respiratory system. So examination, patient is conscious, oriented, afebrile, moderately built and nourished. No pallor, icterus, cyanosis, clubbing or pedal edema. No palpable lymph nodes. Vitals, heart rate 64 beats per minute. So the saturation 96% in room air. Blood pressure 120 over.
Progressive breathlessness, where all you palpate for lymph nodes? Where all you would like to palpate for lymph nodes? Cervical and cervical, nobody will. There is no significance. Listen. Where else you palpate? Emergency medicine is okay. Supraclavicular, yes, told. Supraclavicular, cervical, all these things, one set of group of nodes. Where else? It is very important. Axilla. Axilla is very important. Axillary drainage is from where? Breast. He is a male. Pleura. Pleura drains to axilla. So anybody is having a chronic cough, breathlessness, you are suspecting some sort of chronic disease. Axillary lymph nodes are very important. Okay. So pleura drains to axilla.
Blood pressure 120 over 70 millimeters mercury, respiratory rate of 20. On presentation, the initial ABG was normal, and the point of care CBC suggested a leukocytosis of 21.8 with a differential of neutrophil 76.4, lymphocyte 17.2, and eosinophil 16.6 with a CRP of 19.2. Respiratory system.
What does it mean?
So there's a neutrophilic predominant with elevated eosinophils.
So neutrophils are elevated, counts are elevated, neutrophils are elevated,
Yes, sir.
but eosinophils are also unusually elevated.
Yes, sir.
So that we have to find out what is the reason.
Yes, sir. So respiratory system legal. Upper respiratory tract, normal nasal mucosa, no septal deviation or polyps. Oral cavity, good oral hygiene, no caries. Inspection, bilateral symmetrical chest wall, no spinal or sternal abnormalities. Trachea appears to be in the midline. Chest movements are bilaterally equal with no shoulder drooping or chest retractions. No supraclavicular fullness, dilated veins or sinuses, or any marks of pleural tapping or scars. On palpation, the inspectory findings were confirmed, and the apical impulse was located at the left fifth intercostal space, half inch medial to the mid-clavicular line. The percussion was found to be normal. On auscultation, bilateral laryngery present, diffuse V's present with no added sounds. So, on the basis of the above mentioned complaints, patient is admitted, and on further lab evaluation, the total count was 21.9 with an eosinophil percentage of 46. So, which showed neutrophils of 33, which showed eosinophilia. So, peripheral smear was went, which showed normochromic monocytic anemia with eosinophilia, absolute eosinophil count of 5060.
If a patient is having anemia with eosinophilia, what is the first differential diagnosis? It will come to your mind. Worm infestation. That is the first thing. We have to treat that, then we have to wait for other reports. Okay.
In the peripheral smear, the absolute eosinophil count was 5016 cells.
Okay.
So, which was severe case.
Okay.
So, in the treatment line, patient was started
It's
with
not severe. No? Severe is more than 1 lakh. Mild, moderate, severe. You are telling that class.
Yes, sir. Patient was initially started on augmentin fluid.
What is your diagnosis?
Sir. The patient has eosinophilia, which has to be further evaluated.
What is your diagnosis? Only eosinophilia.
A viral bronchitis is underlying
Viral
eosinophil.
bronchitis with eosinophilia. Okay, eosinophilia may be a separate entity.
Yes, sir.
The thing it is viral bronchitis.
Yes, sir.
You're not suspecting bacterial infection.
So, patient was given 1 start dose of albendazole, and with persistent eosinophilia, patient was also started on diethylcarbazine for 3 weeks.
What is the X-ray finding? What is echo? Is there a need of other investigation? You can know this.
Yes, sir. X-ray was found to be normal. It's just bronchial markings elevated. But other than that, X-ray was normal. Ideally, took sputum studies and maybe a bronchoalveolar lavage would have helped in.
What is the IgE level in this patient?
The IgE was 2496.
It is elevated. That means there is a chronic allergy is going on. We have to find out what is the reason. Then, is there an echo done in this patient? Is there ECG done, ultrasound done? All these things are important. In an eosinophilic case, why should we do all these things?
Sir, other system involvement in certain in vasculitis.
So what are the system commonly involved in eosinophilic syndromes? EAT was happening.
Infiltration of the vessels can
So
cause
what happens?
nausea, gastritis.
So diarrhea, gastritis, all these things. Cardiac?
Cardiac can be valvular pathology.
Valvular pathology is not very common. What else is common? Pericardial effusion can be there. What else? Myocarditis is not myocarditis, it's something else. Endomyocardial fibrosis. Okay. So myocardial involvement can be there. Chronic can become fibrosis. Brain, CNS. It's not common. Huh? Thromboembolic phenomenon can be there. That anywhere it can happen. Encephalopathy not very common. What is very more common? Cranial nerve involvement. Okay. You can get a selective cranial nerve involvement in eosinophilia. Infiltration of cranial nerves. Peripheral neuropathy. Then kidney. Kidney infiltration, vasculitis, all these things are common. Okay. Eyes. Again vasculitis. Most of the areas they infiltrate to the blood vessels and they produce problem there. Should we do a bone marrow in this patient?
Sir, if despite all the because the above said complaints could mostly point to secondary eosinophilia, which is due to an underlying factor. So all the above said factors are ruled out, then we can proceed with the bone marrow to figure out primary eosinophilia.
So most of the time it is because of the allergy, parasite infestation, all these things, and sometimes it can be due to drugs also. Some drugs patient is taking, it can produce. Then it can be like you told idiopathic without any major reason. But there are some conditions which can produce bone marrow problem. What are the bone marrow diseases will produce hypereosinophilic conditions? What name?
Sir,
what name?
Acute
Acute chronic myeloid leukemia also you can get, but acute eosinophilic leukemia you get very high counts. How do you differentiate that from other eosinophilic syndromes? That's what we are doing bone marrow in this patient after 2-3 weeks. Initial 2-3 weeks of treatment, we have to do bone marrow. So what is how do you differentiate? Steroids are different. If you start steroid, everything will disappear. How do you differentiate leukemia from other types of acute bone marrow or production? Blast cell more than 15%, 20% blast cell in bone marrow. They definitely tell it is a leukemia. Okay, so acute eosinophilic leukemia is one of the differential diagnoses, not very common. Okay, but if that is not there, then it has to be something else. Okay. Yes.
So first, eosinophilia can be divided into primary, secondary, or tertiary. Primary are the ones where there's increased proliferation of eosinophils, so mostly suggestive of neoplasms. Secondary are the ones where it's a reactive eosinophilia due to an underlying cause, where once you treat the underlying cause, the eosinophilia should subside. And tertiary is idiopathic.
Okay.
So,
what is leukemioid syndrome? Leukemioid diseases. Is it leukemia or something else? Leukemioid reaction.
Clinical parameters like that, but causation is inflammation.
Just increases the counts due to some irritation, infection, inflammation. Counts are very high, but that doesn't mean that patient is having leukemia. It can be eosinophilic leukemioid reaction or neutrophilic reaction, lymphocytic reaction. Anything can happen. Okay, so that can be something like this also. So after the irritation, it comes down. Okay, there will not be any blast cells more than 10% in bone marrow.
Under secondary eosinophilia with pulmonary with lung involvement, that could potentially be 8 differentials.
Okay.
Under the 8 differential, the most common differential is ABPA or Aspergillus bronchopulmonary allergic bronchopulmonary aspergillosis.
But that what level? The IG level.
IG levels will get elevated.
Yes. So that is one of the differential diagnoses.
Yes, sir. but patient did not have a history of asthma, and blood samples of
How do you
IgG.
prove that that patient is not having asthma? PFT has to be done. So here, without PFT, we cannot diagnose it.
Yes, sir.
So when you are oscillating, you may not get, because you might have done already some steroids or nebulization when they come to ER. Okay. We have to do the PFT and rule out asthmatic episode.
Also, the X-ray would have shown typical fleeting shadows,
Okay.
which
Migrating shadows.
migrating shadows, and the treatment for the same would have been steroids.
Where you get the infiltration in eosinophilic pneumonia? Is it hilar or peripheral? Peripheral is a classical finding. It can get anywhere, but classical finding is peripheral, just opposite of the pulmonary edema.
So ABPA can be two types: ABPA B or S. B has the characteristical central bronchiectasis in a HRCT, while S is just seropositive, where there's no bronchiectasis. So that is the most common differential for eosinophilia and R. The second most common reason would be worm infestation, which can be divided into simple pulmonary eosinophilia or tropical pulmonary eosinophilia. The simple pulmonary eosinophilia is much more lesser in severity. It is either due to a roundworm, threadworm, or hookworm, where the worm enters the body and through the bloodstream. And from the heart, it enters the bronchial airway, and the patient swallows the worm into the GIT, where it matures and proliferates. So during the migration through the lungs, you will get allergic reactions.
What is larva migrants? Larva migrants. What is telling a type of larva migrants only, where the normal tract is lost and it goes to different areas. They produce problem. Normally, you can see on the skin.
Again, you'll have transient shadows in the X-ray, which resolves by itself in 12 days. And the treatment would be albendazole, which was already given, and steroids. Tropical pulmonary eosinophilia would be due to filarial worms, where it's much more severe, where on auscultation, crepitations are normally heard. And chest X-ray would show a middle and lower zone lung field modeling, and IgE will be elevated. On the other hand, for acute pulmonary eosinophilia, IgE may not be elevated, but over here the treatment is DEC for 3 weeks.
What is the dose of DEC?
TID 7 days.
It's a common
TID
problem.
7 days.
TID is
7 days, 100.
I'm asking the dose.
100.
100 of the TID.
87 days.
7 to 21 days.
21 days,
Some
but
book
now
says-
7.
Some books says 1 week is enough. But some books still say it is 21 days. But most recent guidelines say 1
Guidelines
week
are-
is enough. Okay.
Yes. And drug-induced eosinophilia can be a differential if the patient has had any history of recent drug exposure, because
stress syndrome. Stress. Eosinophilic syndrome. What will be the clinical finding?
Eosinophilia is there.
There
Skin manifestation is there.
That is more
Hyperpigmented.
common than pulmonary manifestation. High eosinophil count, skin rashes,
Liver,
secondary
breast.
to lung disease. Sorry, secondary to drug.
most commonly due to certain antibiotics like penicillins,
Okay.
tetracycline, or NSAIDs.
Okay.
So these are the secondary most common differentials involving the lung. Then there are the idiopathic differentials, which is your acute eosinophilic pneumonia, chronic eosinophilic pneumonia, and hypereosinophilic syndrome. Hypereosinophilic syndrome is a diagnosis of exclusion, where after every other primary and secondary cause have been ruled out, you can come down to that diagnosis, and that it affects a lot of the systems in the body. So it can affect your CVS, skin, CNS as well. Then treatment would be steroids and immunosuppressants for that.
Okay. So initially you give albendazole,
Yes, sir.
diethyl citrate. Then if you have doubt, do bone marrow. Rule out leukemia.
Yes, sir.
Then if nothing is there, treat with steroids and immunosuppressants. That is a treatment of choice for hypereosinophilic. You know what happened to this patient afterwards? maybe no English. Bone marrow is advised. Initial treatment was given, but still eosinophil count was little higher. So bone marrow will be done. If bone marrow does not show any malignancy, blast cells are not there, then we can start steroids or some other drug which can spare the steroid. Okay. It may take a longer time to treat. Anything else?
Just have primary eosinophils
Hmm.
pattern of it.
Hmm.
So once you do a bone marrow, you first check for FIP, 1L1 and PDGFR effusion. If that is present, it's suggestive of myeloid or lymphoid neoplasm with eosinophilia. Then you check for certain positional variations such as PDGFRB, FGFR1 and JAK2 because you have selective targeted medical therapies for it.
Okay.
If they are ruled out, then you'll have to check for WHO defined myeloid neoplasms like ALL, AML, MDS. Once they are ruled out, you check for the blast cells, and if it's more than 15%, it's a chronic eosinophilic variant leukemia. Then you look for abnormal T cells, and if they are present, it's a lymphocyte variant hypereosinophilia. And if none of these are present, you look for end organ damage. If any end organ damage is present, it's an idiopathic hypereosinophilia.